and careful in the coming days as we together try to and give the latest scientific evidence coming days to the public, as we together to the world indeed try throughout the rest and give the latest scientific evidence coming days to the public. Speaking in both languages, English and Cantonese, so please bear with us. It will take a little longer than otherwise, and we're going to start. First of all, let me just say that this literally came at 7 o'clock this morning. And Professor Wu and his team have not slept in about 4 days now. And I apologize for the very, very last minute A&E last night, which is when the initial set of findings came out to me. And I actually came back from a business conference in Bangkok. I landed literally 2 hours ago. I think it's important enough that right after we finalized this note, I sent it to the headquarters of the WHO. I understand the Director General is about to land or has just landed in Beijing, and his top team in infectious disease control is in Beijing or is about to be in Beijing. So I sent that team a preprint of the report I'm about to give you at 7 this morning. I've also sent it to the national authorities in Beijing, as well as to our own government, so that we give the latest and the most updated scientific evidence, and therefore I'm now giving it to you just a few hours after I gave it to the World Health Organization. So this, ladies and gentlemen, is the latest official reported confirmed cases. The y-axis on the left that you can see is the total number of confirmed cases as reported by the health authorities on the mainland. And the right-hand axis is the number of cases exported outside of mainland China. And the yellow line refers to the right-hand y-axis, whereas the blue and the red line refers to the left-hand y-axis. As you can see, the curves have a very steep exponential shape, indicating that this epidemic is growing at quite a fast rate, and it's accelerating. So the real question is, given the lag between infection, incubation, symptom onset, and then admission into a hospital, treatment, and then eventually either recovering or perishing from this infection, given that lag, we used our methods, which we described to you the last time, to try and infer how many cases there actually are or were as of 2 days ago in Wuhan and in other places, other large cities in particular, in mainland China. Now, let me just reiterate in English. On the left-hand panel are the expected inferred number of confirmed cases. On the right-hand graph is the expected inferred number of infections. The difference being that those on the right include the pre-symptomatic cases, that is, those cases who have already been infected but are still in the incubating stage of their illness. All right? And the left-hand panel shows the number of clinical or clinically apparent confirmed cases should be somewhere around the region of 25 to 26,000 as of Chinese New Year Day. And on the right-hand panel, inclusive of those who might have been incubating and therefore had not shown any symptoms yet, the number approaches 44,000. Right? So going on next, this is the exact same slide I showed 1 week ago. And this slide shows the travel patterns of Wuhan, which happens to be the major transport and transit hub of central China, extensively connected to and linked with all of the other major city clusters in the country, to the north, south, east, and west. Then this shows a nowcast as of January 25th, Chinese New Year Day, the expected inferred number of exported cases from Wuhan to all of the other major Chinese cities on the mainland, ranging from, as listed in the table on the right-hand side of the slide, 18 cases in Qingdao to a high of 318 in Chongqing. All right? Now, so that's nowcasting. That is just taking a snapshot as of 36 hours ago. If we were to run the model again at this moment, of course, the numbers would be higher. But that is really not the most important point. If we take those numbers then, and we do a forecast, the forecast is, number one, big question. We now have a major population or citywide or cluster of citywide or megalopolis-wide quarantine of population movement, as we've seen since January 23rd and 24th, starting from Wuhan, and then extending to several of the neighboring cities in and around Wuhan. Now, what we did was to do two scenarios. The upper panel shows that if there had not been such a population quarantine, and the lower panel shows that there is such a population quarantine. As you can see, they are almost identical, which suggests that this population quarantine may not be able to substantially change the course of this epidemic in the other major city clusters. It is not to say that it's ineffective, but it may not be able to change in a substantial way. The epidemic curves will develop, or is expected to develop, in these other major Chinese city clusters, as listed. All right? As you can see, this is a rather complicated slide, so I'm just going to take a little bit longer to explain this. On the x-axis is calendar time. It's the American convention where the month comes first. All right? So you see from December all the way to August. And what it shows, these are epidemic curves, or epi-curves, of the major city clusters in the country. Chongqing, Shanghai, Guangzhou, Shenzhen, and Beijing. And as you can tell, Chongqing is expected or projected to have the largest epidemic, mostly arising from the fact that it has a very large population, but also because it has the most intense traffic volume connected with Wuhan. So it's coupled with Wuhan most tightly of these 5 major city clusters. Secondly, you will see that the timing of the peak is somewhere in and around April, May. And what separates out Chongqing from the other 4 is that Chongqing is expected to peak 1 to 2 weeks before the other 4 major city clusters. Again, it is simply a volume and intensity of travel links phenomenon. What we have not shown is the expected epicurve for Wuhan, which will precede that of Chongqing again by 1 to 2 weeks. So we are at the stage where we have not seen the peak of the Wuhan epidemic yet, and then we would expect 1 or 2 weeks later, followed by Chongqing, and then 1 or 2 weeks later, after that, followed by Beijing, Shanghai, Shenzhen, and Guangzhou. Now, a special note on Hong Kong and Macau. Hong Kong and Macau, one mustn't just look at the direct links between Wuhan and Hong Kong and Macau because of the transit arrangements, particularly by rail, between different ports within the Greater Bay Area, but particularly Guangzhou and Shenzhen. And therefore, we were not able to capture or disaggregate that number just for the 2 special administrative regions. So this is the slide that is most complicated. That is why I wanted to spend a lot of time on it. Now, the only remaining element that I have not addressed is up at the top, the 2 lines of text. So, what this graph implies is that in addition to Wuhan, we are expecting to see epicenters of self-sustained or self-sustaining epidemics in these other major city clusters on the mainland. That is, they will not just be exported cases from Wuhan. That the exported seeds will most likely actually start a local epidemic. All right? That is what these epicurves actually mean. The question is, can this be contained within the mainland of China? And given that the 4 Beijing, Shanghai, Guangzhou, and Shenzhen city clusters, they account for 53% of all international travel in the country and 70% of all international air travel outside of Asia originating from mainland China, it is highly likely that if and when they develop their own self-sustaining epidemic, they in turn will go on and seed other major ports as a destination if they were the origin. Okay? The conclusion that we draw from this set of analysis, and that is why it is important that we break this news to you literally on the same day, several hours after we have submitted to the WHO and to our government. The 2019 novel coronavirus epidemic that started in Wuhan, maybe it is not a prediction, but it is in preparation as a precautionary principle. As a precautionary principle, we have to be prepared that this particular epidemic may be about to become a global epidemic. This is not a certainty by any stretch of the imagination, but there is a not weak, or there is not insubstantial probability that this might happen. And therefore, we must prepare better for it. Secondly, it is quite clear that there is already self-sustaining human-to-human spread in quite a number of major Chinese cities. Whether these self-sustaining chains of transmission will be sufficient to spark their own local epidemics, i.e. generate their own local cases over and above what they may be receiving from Wuhan as exported cases. And if that happens, then because we have got at least 4 major city clusters around the country, north, south, east, and west, that have extensive links with the rest of the world's ports, then the chances of seeding sufficient numbers in overseas ports and cities such that they would generate their own local epidemics is not trivial. Again, let me emphasize, it is not a prediction. It is not certain, but these findings makes us concerned enough to alert the authorities and to alert the public so that there is not a sense of uncertain panic, but that we are all kept informed by the evidence, by the science as it develops. But as a precautionary public health principle, it remains incumbent upon us to prepare for that possibility, because that possibility is not trivial. Third, if we want and if we wish and desire to change the course of those epidemic curves that I presented, then we are looking at substantial, draconian measures limiting population mobility that should be taken sooner rather than later. It includes cancellation of mass gatherings, school closures, instituting work from home arrangements within population, but also between population clusters, how do we reduce population mobility? And substantial draconian measures may need to be taken. Should containment fail, that is, if the containment strategy turns out not to work and local transmission is established, mitigation measures during previous major outbreaks like SARS, MERS, or pandemic influenza could come off the shelf again and serve as a useful reference template for public health authorities. And those regions or cities or ports with the closest travel links with the major Chinese ports, as I've outlined, they probably would be well advised to look at their preparedness plans and should ready them logistically for deployment at short notice.
Thank you, Professor Leung and Professor Wu. So once again, please announce your media organization first. I'm going to take this side first this time, okay? 3 from here and then the other side. AFP, please.
Thank you, Professor Leung. I have 3 questions. So would you actually advise the government to also restrict immigration of passengers from the 5 major mainland Chinese cities you have listed so that the government can really get ahead of the epidemic? And the second is WHO is yet to declare this to be a global public health emergency, but you are predicting that it's going to be a global one. So would you actually advise WHO to make such a declaration? And the third question is, how many cases are you estimating, imported cases, are we looking at Hong Kong going to have in the coming days or weeks? And how close are we actually to a communal outbreak? Thank you.
Right. So let me just answer your first question first. You're asking about, in addition to what government announced around 10 or 11 last night about Hubei province, should they do more? As I said, both your first and second questions about the Hong Kong government and the WHO, I have, as of this morning, just after 7, I sent them what I have just shown you. And I think that what I will be saying to both is that we should prepare for this worst scenario, and it is what we think a rather precautionary pessimistic scenario, because this is done without any major public health interventions. All right, so this shows us what might happen if no substantial interventions were to intervene. My advice would be that the Hong Kong government should definitely look at the possibility and not really sort of go and answer the question, should we do more, about more Chinese major metropolitan clusters, or indeed for most of the country, but rather how can we sustain Hong Kong's food supply, Hong Kong's ability and capacity to deal with a major epidemic if we were to interrupt those logistic chains. So the question is not whether or not to do more. The answer to that should become clear with this set of findings. Yes, we must do more. The question really is, how can we make sure that it is feasible, implementable, and enforceable? As to your second question about the public health emergency of international concern, there are more than one criterion in terms of whether and when to declare a fake. I am no expert in the fake definition or the declaration, but I am sure that the WHO and its fake committee members, the emergency committee members, can take reference from our set of findings, as well as those in 3 or 4 major epidemiological modeling teams around the world, with whom we have had close collaboration and contact, and it appears to me that they are coming to similar conclusions. And your third question is about specifically if we were to look into to the crystal ball, how many cases is Hong Kong expecting? The big question is, I don't know. But I think that what you're really trying to ask, if I may, is Hong Kong going to remain only a recipient of the occasional exported cases, or would we receive so many exported cases, whether apparent or not, that they would be able to spark a local epidemic? I think that is really the question. And at the moment, nobody could tell. But I think that that is why we need to do much more and be much more alert and vigilant. There are some things that are at the government policy level, and then there are others at the individual level or at the organization, school, workplaces. And this is the time where we all pull together, and hopefully Hong Kong will be able to pull through this, just as we have for our previous epidemics.
Okay, the second one, CNN, please.
Hi, Isaac from CNN. So what is the WHO's understanding of the virus's capability to spread before common and obvious symptoms show? And there are many people showing up at hospitals complaining of symptoms. And should all of these people be tested, especially in the mainland where there's an overflow in several major hospitals of patients complaining of symptoms? And we're even seeing reports that some patients complaining of symptoms have been turned away from hospitals due to overcrowding. And how does that affect the ability for authorities to be able to contain the outbreak? And finally, how do you handle dealing with so many potential cases when symptoms are not obvious or similar to other illnesses? Oh, sorry, where symptoms are very similar to other common illnesses.
Right. Can I take each of your three questions in turn, if I may? So the first one is, you're asking about the severity profile. So this is really the major question that we don't have an answer to be very, very honest. Anybody who tells you that they have an answer is guessing. What you need to do is really to go and do extensive testing of the full range, the full unbiased, unselected sample of potential cases. Why do I say that? Whatever you do, we have a prior bias, so we tend to test those who show the most symptoms or who are the sickest, because they actually show up in our hospitals and they are so obviously sick that we test them first. All right? So in any kind of emerging epidemic, there is an inherent bias towards seeing and detecting and confirming the sicker patients. What we don't know, because there has not been any systematic study that I'm aware of that actually goes out to, in an unbiased and unselected fashion, go and sweep down the entire clinical severity spectrum. So for example, if you are now in the ICU, if you are now suffering from severe pneumonia, and you have a cause that is otherwise not diagnosed, obviously you'll be tested. But we are not yet testing outpatients, for example, who show up with upper or lower respiratory symptoms. We're not testing everybody who comes in, as you put it, into the emergency room with milder symptoms. And we're definitely not testing nearly enough the close contacts who are not even sick yet, right? Because those would be the people who are likely, if they had been infected, but if they actually don't show any symptoms or mild symptoms, you would get the highest yield. And then finally, you would go and test the general population to see whether they are carriers of this new bug. And because everybody, to be really very, very frank, I think everybody, especially the frontline health workers here and in Wuhan and all over the country, they are really already at the top, at the peak of the capacity that they can possibly bear. It is very difficult, in fact, inhumane, to ask more of them. Secondly, in addition to human resource constraints, you are looking at laboratory capacity constraints. This goes to the surge capacity issue. Do we even have the laboratory capacity to have such a massive ramp up of testing in terms of RT-PCR tests? Do we even have enough lab reagents to run these. And of course, the last thing you need is to have suboptimal quality control where you have an unacceptable proportion of false tests, false positives or false negatives. And therefore, we need to ramp up that validation process. We need to ramp up the volume of tests that one can do. And we need to make sure that there are people to do those tests. And it's not just actually as simple as running a test in a lab. How do you take the sample? If you take the samples in an incorrect or suboptimal manner, you could just as well actually miss a positive case. So everybody is under an extraordinary amount of pressure, as I said, here in Hong Kong as well as everywhere. And that is why we haven't seen those critical studies yet to give us an unbiased view. Whatever we are now seeing or hearing, they are best guesses from our most experienced clinicians and laboratory scientists and public health practitioners who have lived through similar epidemics. But that is no guarantee that we are correct, because even for coronaviruses, SARS and MERS have very different clinical spectrum, very different. And so I think that what I'm hoping for is that viral shedding, which is a proxy for infectivity, how likely an infector is to infect somebody else. If viral shedding is a proxy for infectivity, scales with symptom severity, then we might have a better fighting chance. Let me say it again. That is, if the more symptoms you have, the higher viral load you have, and therefore the virus that you shed has got a higher intensity, and therefore you're more likely to infect somebody else. If that scales, and preferably even exponentially, that would mean that those who show mild or no symptoms are much less infective, or perhaps not even infective. But that is a conclusion that we can only hope for, but we have no evidence of. In preparation, we must prepare for the possible outcome that they are just as infectious. Now, and your question about crowding. Now, of course, when we say, look, within population measures, you want to avoid crowds. But hospitals are a magnet in the event of an unknown, previously unknown pathogen. You are going to attract a lot of people who may have symptoms that are so similar across different bugs, only one of which is this, who all crowd in and want to be tested. And so it is possible that they all come together and there could be a major super spreading event while they all wait in the waiting room. And so I think that capacity control or crowd control within hospitals and infection control under those crowded conditions, it's very difficult. But it is something that I think hospitals should try our level best to manage. Now, there is no perfect solution and there will not be perfect execution. But we're all living in very difficult times, and I think a mutual understanding between those seeking care and those providing care is really critical to us all pulling through. And then third, you said, what happens if there are too many cases to count? There is actually a paper published in The Lancet that from about 8 or 10 years ago, I can't remember now, that we wrote together with colleagues at Harvard, and I'm now beginning to pull that paper out to remind myself what exactly we should do when the numbers become absolutely overwhelming. Next.
Okay, next, Bloomberg, right? And then we'll go over there for another 3 questions.
Hi, so there have been new revelations that the virus can spread during the incubation period when patients are incubating and they're traveling around. Does this mean the virus is more dangerous? And also, does this mean that the current screening measures within China and Hong Kong and Macau are become more inefficient?
It's the exact same answer to what I just explained. So nobody really knows Number one, the clinical spectrum. As I tried to explain the last time, SARS, if you got infected, you will become moderately to severely sick. There are virtually zero asymptomatic cases. MERS is much more like other common respiratory viruses. There's a very large submerged part of the clinical iceberg. What novel coronavirus 2019 is going to turn out to be, we don't know. But it does appear to look slightly more like MERS than SARS. But that's really clinical observations amongst subgroups. And those studies really have not been done. And whatever we're doing now is really the best guess. And as I said, we might have a fighting chance if viral shedding, which is a proxy for infectivity, scales with symptoms. I.e., even though you may be infective, but you are way less infective than if you actually show symptoms or otherwise. So that is something that is a critical knowledge gap that everybody around the world is trying to work on at the moment.